Good morning, everybody. Welcome to Medicine Grand Rounds and Happy New Year. This morning, it's my great pleasure to introduce not our Grand Rounds presenter, but the very wonderful human being who will be introducing him. Dr. Roger Spragg served as professor and vice chair of the Department of Medicine here at UCSD from 1986 to 2006. And also served as the chief of the medicine service at the San Diego VA from 1991 to 2006. During this time, I had the great honor and am indebted to him because he hired me directly out of my residency training into the position that I currently hold at the VA San Diego. And I am just so grateful to him. Dr. Spragg serves as Professor Emeritus at UC San Diego. He will be introducing our Grand Rounds presenter this morning. Dr. Spragg, thank you.
Thank you very much, Dr. Jassel, and good morning to everybody. And one of the best things I did, Zoom, was to persuade you to join our faculty, and I'm always glad that I did. Introducing one's son to Medical Grand Rounds audience is a really special opportunity. So I'm going to try to do my best here and maybe provide a little more deep background than is usual. This has to be every kid's nightmare. David's undergraduate degree is in comparative religion from Harvard, and he's a graduate of Columbia College of Physicians and Surgeons, where he decided to do a research year as a Sarnoff Fellow. And this decision did not surprise his parents. David has always been extremely curious. I can give you an example of that. I remember driving with him one snowy morning in Montana many years ago, and the car was covered with 5 or 6 inches of snow. Now, what kid would reach up and push the button that causes the sliding sunroof panel to open? The phrase, "I just wanted to see what would happen," has become legendary in our family. And the pile of snow in my lap was a vigorous testimony to David's subsequent investigational career. Dave moved on to internship and residency at Mass General and then a fellowship in cardiology at Johns Hopkins. He was appointed to the Hopkins faculty, and he's currently an associate professor there in the Division of Cardiology, specializing in electrophysiology. And he serves as director of the Atrial Fibrillation Research Program at Hopkins and is director of cardiac electrophysiology at Hopkins Bayview. And David's areas of clinical investigation include cardiac resynchronization and therapies for atrial fibrillation. He's authored over 100 original research publications and has a significant clinical and teaching and mentoring load. And his efforts have recently been recognized by appointment to a named professorship, the Edward St. John Professor of Cardiology. It's unusual for a father to have the opportunity to see his son in action. And 4 years ago, we were at about 16,000 feet on our way up Mount Kilimanjaro when a pulse oximeter check that was being done at breakfast time on one of our party reported an irregular beat. The hiker was pretty upset, but lo and behold, sitting next to him at breakfast was an atrial arrhythmia expert. And David took him aside for a history and an extremely abbreviated physical exam, and Dave's wisdom and reassuring manner handled the situation beautifully. And I should add, in addition, the man did very well. And that all is a great segue to the subject of this morning's talk, atrial fibrillation, what's new and different in 2022. So I'm happy and extremely proud to turn the program over to David.
Well, I really appreciate it. My name is David Spragg. I'm one of the cardiac electrophysiologists here at Hopkins. I'm Roger Spragg's son. For the record, what I thought was going to happen is that the dome of snow would stay intact and it would be this sort of cool. All right, well, let me get to where I can advance my slides. So it's nice to have my father introduce me. I wanted to introduce my father to the house staff and some of the younger faculty who I realize may never have met my dad. So this is my father. Roger Spragg when he arrived at UCSD in 1969, good looking fellow there. Someday, Grand Rounds will return in this format. This is Hopkins Grand Rounds, not in the COVID era. And so I hope when Grand Rounds happens in person at UCSD, you get a chance to meet my father. If the ecosystem of Grand Rounds at UCSD is the same as at Hopkins, the speakers down in the front, and then all of the sort of gray-haired emeritus types are down here in the front row, and then there's 1, 2, 3, 4, 5, 6 rows of empty chairs, and then the faculty are back here sort of in the middle of the room. The house staff don't even make the picture. They're way back here in the back where the food is because they know what's up. Anyhow, you can find my father down here. And if you see him, you should get to know him. And you can talk to him about his research career so you can learn about surfactant replacement therapy and acute lung injury. You probably should talk to him about other stuff. You could talk to him about what he was thinking when he walked into his 40th surprise birthday party. And if he's being honest with you, he'll tell you that he's pretty damn glad that he didn't do his usual post-beach routine, which was to undress and clean off in the garage and then come into the house. It's almost a surprise party of a whole different nature. You could ask him about his son's wedding. And, you know, most of us were having a good time. I mean, there's my brother looking good. There's me, a little nervous, but I'm about to get married. There's my mother looking good. And we don't know what was going on with my father. He just had that face for the whole wedding. No, that's not true. You could ask him about climbing Kilimanjaro as a 75-year-old and making it to the top. But what you really should ask him about is mentorship and parenthood, because he's an amazing guy. And it's an unusual opportunity to be in front of a group of total strangers and to get a chance to tell your dad that you love him and how proud you are of him. And so this is a neat opportunity for me. All right. And as Tom Hanks said, there's no crying while giving Grand Rounds. So I'm going to move along here and talk about atrial fibrillation and what's new with AFib in 2022. I don't have anything to disclose. This is what I thought we'd cover today. This is a talk of a certain nature. It's a survey talk with a fair amount of breadth and not as much depth, but I'm delighted to try to answer any questions at the end. What I thought we could focus on is the pathobiology of atrial fibrillation and a bit on the scope of the problem. And then this is really the crux of it, the 4 cornerstones of atrial fibrillation management: stroke risk reduction, rate control, rhythm control, and preventative measures, which deserves a lot more attention than we typically give it. With each one of these areas, I wanted to touch on something new, or new-ish. And so in the world of stroke risk reduction, for instance, we can talk a little bit about left atrial appendage occlusion devices and the work that Dr. Sue and Dr. Crumman do there at UCSD. When it comes to rate and rhythm control, I'm going to talk a little bit about how we probably shouldn't be doing as much rate control as we do, some novel targets for ablation, and then a little bit about digital health in the world of preventative measures of atrial fibrillation. So in terms of atrial fibrillation, this is the rhythm that we're talking about, and you all recognize it, this undulating, chaotic atrial signal in the background resulting in atrial fibrillatory activity mechanically. And with that, the irregular response of the ventricle, often in a tachycardic way. We're going to spend a lot of time talking about the left atrium. So just to make sure everyone's on the same page, here's a cutaway of the heart, right atrium, right ventricle, left atrium up here, left ventricle. You can spin this image around to the right, excuse me, and look at the right atrium, right ventricle, but we're not going to do that. We're going to spin this image to the left and look at the outside of the heart here, the left atrium at the back, the left atrial appendage sticking off. If you keep spinning this image around, we see the back wall of the heart, and we're going to talk a lot about the pulmonary veins, left superior, left inferior, right superior, right inferior, and the musculature that surrounds those pulmonary veins and comprises the posterior wall of the left atrium. We're going to see this view a lot during the coming talk. Atrial fibrillation is a trigger and substrate arrhythmia. This is a figure from the Bill Stevenson recent review of atrial fibrillation in the New England Journal of Medicine. Most patients, when they begin their relationship with atrial fibrillation, start off with paroxysmal atrial fibrillation. they have fairly normal substrate. They have fairly normal atrial myocardium and normal electrical propagation through that myocardium. But they also have triggering beats. They have ectopic atrial foci, typically in and around the ostia of the pulmonary veins. And these ectopic foci are aggressive. They can beat the heck out of this fairly normal substrate. Bam, 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 bam. A bunch of atrial premature contractions that are enough to introduce this normal substrate into fibrillation. Now, the substrate's normal, so that fibrillation tends to be self-limited. These patients have paroxysmal atrial fibrillation. As the patient ages with senescence, with hypertension, with ischemia, with sleep apnea, with alcohol exposure, they tend to build up fibrosis, interstitial fibrosis in and amongst these atrial myocytes. They still have ectopic atrial triggers. Electrical propagation through this more deranged substrate is now decidedly abnormal. And so triggers induce atrial fibrillation, and the atrial fibrillation tends to last. People with episodes of atrial fibrillation that last longer than a week in duration are defined arbitrarily as having persistent atrial fibrillation. As the patient ages further, as their atrium gets more and more disturbed, more and more interstitial fibrosis, it doesn't take much. It doesn't take one of these aggressive triggers. It takes any old PAC, any old premature atrial contraction, to tip this fragile atrium into atrial fibrillation. The AFib tends to last and last. Episodes that last longer than a year are defined as episodes of long-standing persistent atrial fibrillation. And patients often progress from paroxysmal to persistent to long-standing persistent if we don't intervene. Those little cartoons are not just cartoons in a Bill Stevenson review article. These are real, and it's based on the work of Michel Hasseguer in Bordeaux, France. He studied a bunch of patients with atrial fibrillation in the mid-1990s and observed that triggering activity arising from the pulmonary vein ostia. So this is from his seminal work in the New England Journal of Medicine. Patient begins the strip in sinus rhythm, P wave, and a QRS complex. There's a measuring catheter in the right inferior pulmonary vein, and then bam, 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 very rapid PACs at over 300 beats a minute, and that induces this run of atrial fibrillation seen on the right-hand side of the screen. So those pulmonary vein triggers are actually real. The fibrosis is real. You can assess fibrosis in a number of different ways. This is a study that we did to compare assessment of fibrosis by delayed gadolinium-enhanced MRI versus direct mapping, putting a catheter up into the left atrium, touching atrial tissue and looking at local voltage and building an electroanatomic map. And you can see that in patients like patient number 1 who have paroxysmal atrial fibrillation, there's a lot of normal tissue, blue, and a little bit of fibrosis, red, a lot of normal tissue, purple, and a little bit of fibrosis. In patients 2 and 3 who have paroxysmal persistent AFib, with both MRI assessment and electroanatomic mapping, lots of fibrosis that accounts for their more persistent atrial fibrillation. Hugh Hopkins, when he put together his expert consensus document on dealing with atrial fibrillation, acknowledged that deranged conduction because of substrate disorder, acknowledged those pulmonary vein triggers and sometimes triggers from other sites. There's also autonomic ganglia that invest the posterior wall of the left atrium, and you put that big hot mess together, and that's some of the pathobiology of atrial fibrillation. It is a massive problem. So the people at Mayo Clinic looked at Olmsted County and said back in the early 2000s, if rates of obesity and diabetes and hypertension and ischemic heart disease stay at current levels, then the burden of atrial fibrillation in the United States over the next few decades will look like these dark balls here, and we'll have 12 million people with atrial fibrillation by the year 2050. If rates of obesity and all of the attendant comorbidities with obesity continue to increase, then the burden of atrial fibrillation in this country is going to be 16 million people by the year 2050. We are not alone. So in the Guangzhou Heart Study in China, The overall prevalence of atrial fibrillation for the whole population is something about 1% or so. It's an age-related prevalence, so the older you get, the higher the prevalence. But for the global population, the burden of AFib in China is something around 1%. So already we're talking about tens of millions of patients there. In Europe, the same story, that by 2060, there's going to be 20 million, 18 million people with atrial fibrillation. So this is a worldwide epidemic. I lie to my patients when they come in and see me with atrial fibrillation. I tell them, we're going to make sure you don't have a stroke, which is the biggest deal. And otherwise, atrial fibrillation is a nuisance arrhythmia. It's not going to kill you. And that's true in the individual sense. There is clearly a mortality signal in patients with atrial fibrillation. So again, this is from the Mayo Clinic group. They compared patients without atrial fibrillation to those with atrial fibrillation, and there's this clear reduction in survival. Some people have atrial fibrillation when they are critically ill from other things. Someone comes in septic to the MICU, and they've got a little AFib on their way out. If you take that out of the equation, if you say that there's a 4-month blanking period from AF diagnosis to mortality, there still is this depression in survival curve. And we haven't done better with that over time. So if you compare 1980 to mid-1980s to all the way up to the year 2000, those poor survival curves are superimposable. That's the bad news. Oh, and this is what people die from: increased risk of stroke, increased risk of heart failure, increased risk of myocardial infarction, and the consequences of dementia. So that's all the bad news. The good news is that in the last 20 years, there's been a lot of progress in the world of treatment of atrial fibrillation. And so this is the 4 cornerstones of therapy. And I'm going to start with the most important one, which is stroke risk reduction. When patients have atrial fibrillation, they tend to have a propensity for thrombus formation, particularly in the left atrial appendage. Thromboembolic stroke from patients with AFib accounts for about 20 to 25% of thromboembolic stroke writ large. There are comorbidities that are associated empirically with who is likely to have a stroke. It used to be easy. We just had to remember CHADS: congestive heart failure, hypertension, age, diabetes, prior stroke. Things got a little more complicated when the scoring system got a little more robust. And so we talk a lot about the CHADS-VASC scoring system: congestive heart failure, hypertension, age over 65, age over 75, diabetes, prior stroke, vascular disease, and SC is sex category. You get a point if you're a woman. And each one of those confers an increased risk of stroke over time in patients with atrial fibrillation. When you start summing those together, this is the stroke profile that you see, that if you have a CHADS-VASC score of 2, you have an annualized stroke risk off of anticoagulation of about 2, CHADS-VASC of 3, about 3, CHADS-VASC of 4, about 4. If you really have all the CHADS-VASC risk factors, chance of having a stroke off of anticoagulation is about 15% in any given year. And so the American Heart Association and other guideline producing agencies have said for a man with CHADS-VASC score of 2, woman CHADS-VASC score of 3, those patients should be anticoagulated to reduce their risk of stroke in the setting of atrial fibrillation. And there are lots of good options for anticoagulation. There's old school and there's new school. So this is old school. I'm not a big reader of the British Journal of Hematology, but I might start to become a big reader after reading this article. It's fascinating. This is Carl Link, the person who discovered dicoumarins. And the story is fantastic, that it was in John Steinbeck's Grapes of Wrath America, 1920s, 1930s. Farmers were poor. Farmers in the upper Midwest were feeding their cattle sweet clover hay, but they were poor, so they could only afford old, junky, moldy sweet clover hay. And the cows were eating this moldy hay, and they were dropping like flies. They were bleeding to death. And so there was a farmer who drove 200 miles through a blizzard with a dead cow and a bucket of uncoagulated blood in the back of his pickup truck. He drove all the way to the University of Wisconsin, and he found an open door. And it was the open door of a biochemist, Carl Link, who was funded, by the way, by the Wisconsin Alumni Research Organization, WARF. And so you can see where this is going. And Carl Link said, great, give me the blood and we'll test it. And he identified that the mold was producing this molecule, dicoumarol, and that was the anticoagulant. And so they said, okay, if it kills cows, it'll kill rats. And so they turned it into a rodenticide. And then Eisenhower had his heart attack in 1955 and got treated with Coumadin, and it started becoming used popularly as a therapeutic agent for patients with atrial fibrillation. A lot of that work was done by one of my mentors at Mass General, Elaine Heilich. She worked with Danny Singer. And what they found is that patients who were on warfarin for prevention of stroke in AFib, who showed up with a stroke, tended to have INRs in the range of 1 to 1.5. If you didn't have a stroke, your INR tended to be 2 to 3. And so there was born the therapeutic target of an INR of 2 to 3 with warfarin for preventing stroke in AFib. Now, anyone who's managed a patient on warfarin knows that warfarin is a crappy drug, that with a little bit of dietary change, a little bit of change in gut flora, that the INR can shoot all over the place. And so there were a series of drugs developed in the early 2000s and a series of New England Journal publications a decade later that have given us the world of direct oral anticoagulants. I'm just going to check on the question. Oh, yeah, I just wanted to make sure it was that no one could hear me. All right, I'll come back to that question at the end. So there have been a series of studies looking at these direct oral anticoagulants. All of these studies were designed as non-inferiority, and all of them ended up showing, I think all of them ended up showing superiority of dabigatran at the dose that we give it, 150 milligrams twice a day, had a lower stroke risk of stroke on the y-axis here, than warfarin. And rivaroxaban, Xarelto, 20 milligrams a day with food. You got to give this drug with food because it's critical for absorption, did better than warfarin. Eliquis, 5 milligrams twice a day, apixaban, did better than warfarin. I use a fair amount of apixaban because there's safety data showing that the bleeding rate of patients on apixaban is fairly comparable to that of aspirin. So you get a patient who says, well, I don't want to be on a blood thinner, I'll just take an aspirin. You can hit them with this data and convince them that they ought to be on a real anticoagulant that actually reduces stroke rate. So we have a good armamentarium of drugs to prevent stroke, and we have a good scoring system to identify who should be on those drugs. Here are some of the subtleties. The one I'm going to start with is the one at the bottom, which is that we do a lousy job as a medical community in anticoagulating people. And part of it is that we're put off by fear of old bleeding. Someone had nosebleeds, someone had hemorrhoids, whatever. Having a GI bleed is not the same as the permanent damage that can come from having a thromboembolic event. And so Elaine Heilich really pounds on this, that we need to be more aggressive about starting patients on an anticoagulant. I'm not trying to be glib, but if you start someone on Eliquis and they come in with a GI bleed, fine, they get a little blood, you stop the drug, at least you've tried, and you can talk to them about what I'm about to talk about, which is the non-pharmacologic way of stroke risk reduction. But we need to be trying that in more patients. Greg Lipp went back and looked at how many patients are appropriately anticoagulated, and it's something in the range of 50 to 60%. We are leaving a lot of strokes on the table, and we need to be better. There are some other subtleties. How much AFib counts in terms of committing someone to a lifetime of anticoagulation? And here the data is a little bit variable. Excuse me. Some data show that having PACs confers an increased stroke risk. I think most of us say that if there are minutes of atrial fibrillation, 6 minutes or more of atrial fibrillation seen on a monitor, that's enough to say, okay, you really have atrial fibrillation. Does the setting of AFib matter? If someone has AFib in real life, that probably is the real deal, and we ought to be anticoagulating. If a surgeon gets in there to do bypass surgery and she's handling the heart and causing inflammation and irritation, lots of patients have post-op atrial fibrillation. If a patient only has post-op AFib, we should probably anticoagulate them around that event. But then I don't commit those patients to a lifetime of anticoagulation. I typically survey with an event monitor, and if they don't have AFib in real life, I say, okay, that was just a bit of post-op AFib. It can be hard to manage patients who are already on anticoagulants for good reasons, like a fresh stent. And so if someone is on dual antiplatelet therapy and they have AFib, that can be a pretty aggressive regimen. It's worth talking to the interventionalist and see what she wants to do in terms of how long Plavix needs to be around. Oftentimes for these kind of patients, I have them on a DOAC and aspirin once they get past that Plavix phase. And then there's an interesting question for people who think about cost to society. Warfarin is free, DOACs are expensive. The cost for one quality of life year adjusted to have someone on a DOAC has been calculated at about $21K. And so there's an interesting discussion to be had here about what kind of drugs we ought to be using. I think individually, there's a strong argument for DOACs. I think from a societal cost perspective, patients who are doing well on warfarin, stable INRs, I tend to leave them on warfarin to save us all a little bit of money. What's new in the world of CVA risk reduction? Well, this is new-ish, and that's the world of left atrial appendage occlusion devices. And so Dave Crum there, Jonathan Sue, put these devices in. For patients who can't be on a blood thinner, it's recognized that most thrombi form in the left atrial appendage. And so there are devices, Amplatzer, Watchman, which is what most people use. There's a lasso that goes up and around the left atrial appendage to cinch that baby off. The general idea is that you implant or tie off one of these devices, no blood can get into the left atrial appendage to form clots. And the data here is good for patients, excuse me, who can't be on a blood thinner. Registry data like Evolution in Europe that looked at over 1,000 patients showed that you can put in these devices 99% of the time, that most of the patients post-device are on a single antiplatelet agent like aspirin, and that the reduction in anticipated rate of stroke to observed is really quite striking. Anticipated rate of thromboembolism in general to observed rate of thromboembolism, very similar to that seen with systemic anticoagulation. Bleeding goes down as well. So the point that I want to make there is that we under anticoagulate patients as a medical community. We're not aggressive enough. We ought to anticoagulate people more often according to guidelines. And if you can't anticoagulate someone because of bleeding risk or because of actual bleeding, there is an alternative, which is an invasive but reasonable procedure to occlude the left atrial appendage. The next cornerstone of therapy for atrial fibrillation is rate control. A lot of times patients with atrial fibrillation show up with minimally symptomatic, quite rapid atrial fibrillation, and it's minimally symptomatic until they develop a big blown out tachycardia-induced cardiomyopathy. And so there are a whole set of agents, beta blockers like metoprolol, calcium channel blockers like diltiazem, that are designed to control the ventricular response rate in the setting of atrial fibrillation, rate control. That's different than rhythm control, which is where you cardiovert someone or put people on an antiarrhythmic drug to restore normal sinus rhythm. Those are the two major arcs of therapy, rate control versus rhythm control. This is an oldie but a goodie, 2002, the AFFIRM study that compared those two approaches, rate control versus rhythm control, and the results were nearly superimposable. If anything, there was a trend towards reduced mortality with a rate control compared to rhythm control. Over 4,000 patients in this study. And so this has really bolstered a lot of people's argument that rate control is sufficient in atrial fibrillation. There was a companion study around the same time, the RACE study, again comparing rate control to rhythm control through cardioversion, and then this iterative process of trying people on different antiarrhythmic drugs, rate control with simple drugs like beta blockers or calcium channel blockers. And again, very similar survival curves, if anything, a little bit better in the rate control arm than the rhythm control arm, although not significantly different. Now, the subtleties, I mean, there are a bunch of caveats to say there. So in AFFIRM and in RACE, not many, in 2/3 of AFFIRM patients and in 1/3 of RACE patients, the rhythm control arm actually achieved rhythm control with some spot EKG monitoring. So it may not have been a great comparison of rate control versus rhythm control. AFib can cause very insidious symptoms. Leaving people in atrial fibrillation is a one-way street. The more AFib you have, the more atrial remodeling will occur and the more AFib a patient is likely to have. Therapy has gotten a lot better over the last 20 years. New drugs like dronedarone, new approaches like ablation. We don't have a lot of ultra long-term follow-up in terms of leaving people in atrial fibrillation. And there's some new appreciation of the harm from atrial fibrillation. So the take home that I have, what's new with rate control, is that we perhaps should not be doing as much rate control as we are. There's this newfound appreciation that AFib is linked to stroke and LV dysfunction, dementia, depression, impaired quality of life. And so some of that realization and some of the newness of therapy, new drugs, new ablative techniques, led to a recent study a couple of years ago now in New England Journal of Medicine, EAST-AF4. This was a new version of rate versus rhythm control. So nearly 3,000 patients, in the end, 1,400 in each arm or so. There was the rhythm control arm, patients treated with antiarrhythmic drugs, a little bit of ablation in blue down here. And there was the rate control arm. And in outcomes, rhythm control had a reduced cumulative incidence, of cardiovascular death, stroke, hospitalization from heart failure or ACS, a reduction in that combined endpoint in rhythm control versus standard care. And that was statistically significant. In fact, the study got stopped early. And so in my practice, if someone is old, and old is not a number, old is a physiologic state. If someone's old and truly asymptomatic, if my dad at 75 is climbing Mount Kilimanjaro in atrial fibrillation, fine, you're kicking butt, rate control. But if someone is old and symptomatic, or if someone is young and symptomatic, or young and asymptomatic, I tend to nudge those people towards rhythm control based on this data. Sometimes people say, I don't know if I'm symptomatic. And so for them, we do a test. We put them on amiodarone, not for long term, but just to do the test. We bring them in and cardiovert them, and they keep a little diary before and after cardioversion to tell me if they're better in normal sinus rhythm. If someone has very long-standing AFib, or I don't know how long it's been around, but their atrium is big and blown out, I generally do rate control in those people because restoring sinus rhythm is next to impossible. And as you can imagine, this is a discussion where shared decision-making is very important. But the take home that I wanted to have for that section is that we've leaned on Affirm and RACE to justify rate control in a lot of our patients. And there's new data to suggest that we don't fully appreciate the harm from AFib. There are new approaches at rhythm control, and we probably should be giving more patients a chance at rhythm control when they're first diagnosed with AFib. How do we do rhythm control? Well, there's two options. There's drugs and there's ablation. So if a patient shows up in atrial fibrillation, we say, okay, we're going to pursue rhythm control. Then you can do drugs or ablation. If someone is totally healthy from a cardiovascular standpoint, they get to choose. The drugs can be 1A drugs like flecainide or propafenone, or we can do catheter ablation as first-line therapy. If someone's sick from coronary disease, we don't give sodium channel blockers, and so the drugs are sotalol or amiodarone. If someone has heart failure, I might use Ticacin. Sometimes we use amiodarone. But fundamentally, the choices are drugs or ablation. These are chronic suppressive drugs. It's not an antibiotic where you take it for 10 days and you're fixed. It's chronic suppressive medication. Drugs don't work that well. So the heaviest hitter that we have, amiodarone, with all of its toxic side effects, if you put someone on amiodarone and look 2 or 3 years down the road, about 60% of those people will have maintained sinus rhythm. The drugs that we use that do not cause pulmonary fibrosis, liver injury, and thyroid injury, like sotalol, like propafenone, work in about 50, maybe 40% of patients. So drugs are not a panacea. The other thing that it's important to tell patients is that drugs may work for a while, but then patients may have breakthrough episodes of atrial fibrillation. It's not that they forgot how to make the drug. It's that the patient's gotten more beaten up over time and their propensity for AFib has increased. So the other option for patients who don't want to do drug therapy, or for patients who have tried suppressive antiarrhythmic therapy and have had either intolerable side effects or breakthrough atrial fibrillation, basically for patients who can't take drugs, this is the alternative. Now, this isn't the alternative. This is old data from James Cox, cardiac surgeon at WashU, who said, I know what to do about AFib. And what he did was disarticulate the atrium. He'd take the right and the left atria and slice and dice. He'd cut off the appendages. Interestingly, he'd go around the pulmonary veins here. He'd make these long incisions and then suture the atrium back together. The idea was that these suture lines form lines of conduction block, and so fibrillation couldn't occur in this disarticulated atrium. Catheter ablationists seized on this data from Michel Hassaguer, said, okay, we know where the spots are that beat rapidly and that trigger atrial fibrillation. We know that it's the pulmonary vein ostia that house these pieces of atrial myocardium that pound the atrium into fibrillation. And so a lot of us now spend our lives doing catheter ablation of atrial fibrillation. Patients knocked out under anesthesia, we introduce a catheter up into the left atrium, and then either by point ablation here, we go around the pulmonary veins. There's an alternative strategy where you can put a catheter up and introduce a balloon that touches against the ostia of the pulmonary veins. So this is from Karl-Heinz Cook's fire and ice study. The ice was freezing. The fire was point ablation. Doesn't matter how you do it. The idea is that you take a patient whose atrium looks like this. Purple is normal voltage activated or voltage activating tissue, muscle. And you can see that there are these tongues of muscle that extend up into the pulmonary veins. And so we introduce a catheter, and either by freezing or by heating, we ablate in a wide circumferential way. We ablate a linear lesion around the left and the right pulmonary veins. That ablated tissue turns into scar tissue, which is electrically non-conductive. And so in sinus rhythm, electricity can't get across that line, can't get up here to activate that tissue. That's entrance block. We don't give a damn about entrance block. What we care about is exit block. What we care about is if there's a pulmonary vein focus in that little cone of muscle, now that sucker is behind this wall of ablated tissue. And so if it decides to fire rapidly, those beats can't get down into the atrium to stir up atrial fibrillation. That's the general idea, pulmonary vein isolation for the catheter ablative treatment of atrial fibrillation. In patients with paroxysmal AFib, fairly normal musculature, not a lot of scar tissue, that works reasonably well. So this is data, again, from that fire and ice study. Cryo and radiofrequency ablation work the same. That's not the point of this. The point is that if you look a year out, about 2/3 of patients will be free of any recurrence of atrial fibrillation post-ablation. There's a newer study, Circadose, that looked again at cryo versus a different kind of cryo versus RF. That's not the point I want to make. The point I want to make is that in Circadose, where they really monitored aggressively, implantable monitors to detect any little drop of atrial fibrillation, freedom from atrial arrhythmia in Circadose was about 50% of patients or so at 1 year. Freedom from symptomatic atrial fibrillation was about 80% of patients or so. If you threw the kitchen sink at people and did multiple procedures, total freedom from any atrial arrhythmia was about 2/3. You might be saying to yourself, wait a second, I thought you said this was a pretty good procedure. Well, the real data is this, that the reduction in AFib burden in these patients with paroxysmal AFib was about 99%. So patients would spend about 2 to 4% of their life having these miserable episodes of atrial fibrillation. And with any ablative modality, you reduce that burden of atrial fibrillation by about 99%. And that's what I mean when I say it's a pretty reasonable procedure. Now, that's true for patients with paroxysmal atrial fibrillation. Not a lot of scar tissue, aggressive triggers. What about patients with a lot of scar tissue and a little bit of triggering activity? And the truth is that we're miserable with that. Ablative success rates for persistent AFib are not good. The Bordeaux group, that same Michel Hassaguer group, said, we know what to do. Ablate everything. Ablate the pulmonary veins, ablate the posterior wall, coronary sinus, superior vena cava, ablate everything. A lot of patients will go back into normal sinus rhythm. Well, if you look over time, doesn't matter if they restored sinus or not, those patients did miserably in terms of recurrence of atrial fibrillation. Sanjeev Narayan really blew the field up and identified important pathophysiology when he was there at UCSD. He said there's rotor activity in and around scar tissue, excuse me, and we can find and modulate that rotor activity through firm guided ablation, and that's going to cure AFib. And there are patients where that's the right approach. Now, this is a meta-analysis showing why this hasn't totally taken over the universe in terms of ablating persistent atrial fibrillation. In this meta-analysis, if you look at success rate on the x-axis here and compare just straight up pulmonary vein isolation versus pulmonary vein isolation and firm ablation, there was not more success with including firm guided ablation. The only thing it did is make the procedure longer. But you're going to see in our research here at Hopkins, we really like this idea of rotor supported ablation and targeting those rotors. In New England Journal of Medicine, there was a study looking at pulmonary vein isolation versus PVI plus ablating magic spots versus PVI plus putting in empiric lines. And the take home is that pulmonary vein isolation only was the superior form of ablation, that doing more ablation didn't do better in terms of freedom from AFib. So the holy grail right now, or at least one holy grail, is how to ablate persistent atrial fibrillation. At Hopkins, this is our idea. This is a methods paper that we put out in Nature Biomedical Engineering. The idea is that everybody gets a cardiac MRI. From that cardiac MRI, we get atrial anatomy. We can identify scar tissue because it's a delayed GAD enhanced cardiac MRI, and we can come up with a personalized atrial model, including anatomy, including fiber orientation, including scar distribution. We're working with Natalia Trayanova in biomechanical engineering. She takes that data, she builds an in silico model of that patient's atrium, stimulates that atrium, and induces atrial fibrillation. That group identifies the rotors, the same kind of rotors I think that Sanjeev Narayan may have been targeting, identifies those rotors, and then in silico ablates those rotors, conduction velocity to zero, reinduces atrial fibrillation in this iterative process, and finds the 2, 3, 4 rotational spots that seem to support AFib in that particular patient's anatomy. That information is exported into our imaging system that we use during AFib ablation, and we target that piece of tissue. So here's a cartoon from a particular patient, posterior wall of the left atrium, right atrium coming around. Gray is normal tissue, green is scar tissue, and in the model, that patient had, on this posterior view of the left atrium, clear rotational activity just outside the right inferior pulmonary vein. If you look at the front of the atrium, there's clear rotational activity around the base of the left atrial appendage. And so in addition to pulmonary vein isolation, those particular spots were targeted for ablation. We don't know if this is going to work. We're doing a prospective randomized study looking at PVI only versus PVI plus model targeted ablation. We're about 20 patients into enrolling 200 patients. And hopefully in a couple of years, I'll get to present results at a venue like this. Okay, the last thing that doesn't get enough airtime, and so I wanted to give it a few minutes, are the preventative measures that we should be doing for patients with atrial fibrillation. Not talking about stroke prevention, I'm talking about obesity and all of the crap that goes along with that. So the real driver of this field has been Prash Sanders down in Australia. They started out by creating a lot of obese sheep. They said, let's look at the effects of obesity and try to divorce it from confounders like sleep apnea. And it turns out that obese sheep don't have sleep apnea because they sleep standing up. So they took a bunch of sheep and they made them chubby. And then they performed EP studies on those sheep. They looked at tissue fibrosis. They looked at pericardial fat. And there were a significant number of pro-arrhythmic changes that happened just from obesity alone. So they said, okay, if we can push sheep into obesity, maybe we can pull patients out of obesity. So here's a study where they found nearly 300 patients. They pulled out the ones that were a little bit chunky, BMI greater than 27. And I say that as someone, by the way, who would love to have a BMI of 28. And they said, okay, we're going to offer everybody aggressive risk factor management. And 69 patients said, yes, please. 96 said, no, thank you. And then they followed how those groups did post-ablation. And what they found is that if you look here on the y-axis, single procedure AFib-free survival, that if they performed one AFib ablation, that the freedom from AFib in the weight loss group, the risk factor modification group, was about 60%. Freedom from AFib in the group that didn't accept risk factor modification was about 30%. If you threw the kitchen sink at people, did multiple procedures, the results were a little bit better. They performed a larger study coming up with 335 patients, and everybody got risk factor modification. You didn't get to say no. And they looked at weight loss and they looked at weight fluctuation. And there was a group that lost a little bit of weight, medium amount of weight, a lot of weight, greater than 10% of their baseline. There was a group that had linear weight loss, weight fluctuation, and no loss or weight gain. When you didn't do any procedure, this is ablation-free, drug-free, freedom from AFib. So this is just the effect of weight loss. Red is the group that lost greater than 10% of their body weight, and they were free from AFib. No other intervention about 50% of the time. If you didn't lose a lot of weight, you had more AFib. If you did procedures like ablation, maybe multiple ablations, the group that lost weight did best. The groups that didn't lose weight didn't do so well. And so they came up with this idea, they've really pushed this idea that obesity confers a lot of risk for atrial fibrillation, hypertension, diabetes, sleep apnea, dyslipidemia, importantly, pericardial fat and inflammation under that pericardial fat. And then if you can reduce obesity, you can reduce the drive for atrial fibrillation. This is another risk factor modification study that came out recently, pissed off a lot of my patients. It gives everyone hope. I mean, here you can take 70 patients in each arm for a fairly simple study. Bam, New England Journal of Medicine. I mean, that ought to give everybody a little bit of hope. Anyways, they found 140 patients who were living it up, greater than 10 drinks per week, who had atrial fibrillation, some paroxysmal, some persistent. Everybody started the study in sinus rhythm, and they said, okay, you 70 patients, you got to cut it out. No alcohol for you. You 70 patients, keep the party going. And what they found is that the recurrence rate of atrial fibrillation was significantly higher in the group that kept on drinking. The lines are shown here. And that the median amount of time in AFib was over double in the group that kept drinking compared to the abstinence group. Preventative measures are hard. And I say that as someone who has trouble with weight loss himself. I mean, I can't look at a patient and say, you got to lose weight, physician, heal thyself. And the mechanisms that Prosh Sanders was using to get this kind of data were really intensive weight loss management clinics. At Hopkins, what we're trying to do is develop an app for that. And so this is sort of the unwieldy title, Patient-Centered Mobile Health Technology Enabled Atrial Fibrillation Management. I'm not responsible for that. It's a randomized clinical trial. MTech is what we're calling it. And it's developing an app to address these modifiable risk factors. So it's based on this idea that risk factor modification really works if you do it aggressively, but we don't do it. There's also underutilization, as I hinted before, about stroke prevention medications and initiation of rhythm control strategies, and everybody's got a phone. So Seth Martin and Nino Isakadze, Seth is one of our preventative people here, and Nino is a rising EP fellow, developed Corey. Corey is modeled after a post-MI app that we've been using here. This is targeted more to atrial fibrillation, and hopefully these little guys will play. But there's a lot of features that we built into this, including educational activity, including demos about how AFib ablation works. I like the little steam that rises up from that ablation lesion, including bits on cardiac physiology. There are ticklers to remind patients about, let me get this to advance. Excuse me, ticklers to remind patients about taking their medication. Ticklers to get up and move around and get out of your chair and exercise. There's some proprietary stuff with companies that are designed to look at and detect rhythms using smartphones. And we're still talking to those people about how patients can gather data for the physician when they think they're in AFib. It's a pretty humble stage that we're at right now. We're looking for just over 100 patients in outpatient settings. They're going to be randomized to standard care, which is a physician saying, try to exercise and lose weight, versus this intervention. Given a phone, given the app, we're going to follow up at 12 weeks. The primary measure is just to see if people can engage in the app, that there are tasks to do, and we're hoping that more than half, that maybe 2/3 of patients will engage with all of the tasks in the app. We're also going to collect data. We're going to look at quality of life and AFib burden, heart control rate, hospitalization rates, use of CPAP in patients with sleep apnea. And then that'll hopefully give impetus for a larger study to see whether an app to remind people about risk factor modification in the world of AFib is helpful. So what I've tried to cover in that whirlwind tour is that AFib is a trigger and substrate arrhythmia. There are pulmonary vein foci, sometimes other foci, that stimulate the atrium and induce AFib. If the substrate is really messed up, that tends to be persistent AFib. Early on, when AFib is the most fixable, the substrate is fairly normal, paroxysmal AFib. It is a huge public health issue. The main thing to do is make sure people don't have a stroke. This is the reason for 20% of thromboembolic strokes, and we know how to prevent that. There's more data recently to show that assigning patients to a rhythm control strategy, be it drugs or ablation, might be justifiable. Drugs aren't perfect. Ablation is reasonable in those with paroxysmal AFib. That's why we like to meet people early. It's always a shame to meet people once they've had a couple of years of persistent AFib. We're working on persistent AFib and how to ablate that. We're also working on developing an app to try to target lifestyle modifications. So this is a summary feature or a figure from that Bill Stevenson article. I think we touched on it. We touched on rate control. We touched on rhythm control. We touched on modifying risk factors, and we touched on different ways to ablate atrial fibrillation. I know that was a rush, but it looks like we've got 10 minutes left or so, and I'd be very happy, again, to tell my dad that I love him and to answer any questions.
Dr. Spragg, thank you so much for that really comprehensive and thought-provoking presentation. We have a question from Dr. Rubin. Are acquired mutations of the RYR2 gene under-recognized as an etiology for AFib? Should a trial of flecainide be considered as therapy to restore normal rhythm?
That is a great question. So I don't speak, thank you, Dr. Rubin. I don't speak the language very well of genetically induced mutations as a cause of AFib. I spent a lot of time up at Mass General, and Patrick Eleanor up at Mass General really leads that effort, looking at some of the genetic drivers of familial atrial fibrillation. So I'll have to ask Patrick about that. It just so happens that FLEC is a favorite drug that I use. It's not because it's not because I'm intelligent enough to be speculating that ryanodine mutations are a major driver of atrial fibrillation. It's just a drug that's effective, maybe for that reason, and that's well tolerated. So I do use a lot of FLEC, although not for the intelligent reason that you're asking about. The author that I would suggest looking up, and for all I know, you're best friends with him, is Patrick Eleanor up at Mass General, because he does a lot of that work.
Thank you. From one of our third-year residents bound for cardiology, Dr. Mila Varapu, over what time frame was post-procedural AFib burden determined in the paroxysmal AFib study comparing pre-procedure and post-procedure time in AFib?
Oh, comparing pre-procedure. I'm not sure I understand the question. I mean, typically for AFib outcome studies, and I know you know this, there's a blanking period of 3 months, which is probably too long because we know that if you're going to have recurrence, that the recurrence that counts is anything after 45 days or so. Most of the AFib studies that I've looked at look at 1 year outcomes or maybe 2 or 3 year outcomes. I don't know the answer to how long post-procedure people looked at in studies that looked at AFib burden pre-procedure, if I'm understanding the question correctly. So email me after this and I can try to come up with a more intelligent answer. But I think my answer for right now is I don't know. Oh, you might be muted.
Sorry, thank you. From Dr. Mohammed, what is your opinion of the Watchman device strategy?
Well, I think Watchman is great. I don't implant Watchman. It strikes me as deadly dull, so I haven't chosen to do that as my life. But I think Watchman is a really good option for patients who can't be systemically anticoagulated. There's old pathology data that shows that most of the thromboemboli that occur, but not all of the thromboemboli that occur in patients with atrial fibrillation originates in the left atrial appendage. And that number gets batted around as 90%, 95%. Well, anticoagulants treat everything everywhere. and Watchman treats the left atrial appendage. So when a patient comes to me and says, which should I do? Should I be on Xarelto, chronically, or should I have a Watchman implanted? I tell them to take a systemic anticoagulant because I think that treats the potential for thrombus formation, even at sites, those rare sites outside of the left atrial appendage. There's also a little bit of a procedural risk with Watchman. With that said, if a patient doesn't want to be on an anticoagulant and they're sitting there saying, look, I'm just not going to take a drug, well, then Watchman is clearly the right answer. If a patient takes an anticoagulant and has any kind of issue with it, Watchman is clearly a very good answer. And so I'm very pro Watchman. I hope that addresses the question.
Thank you. And from one of our chief medical residents, also bound for cardiology, Dr. Martinez, do you believe the utilization of smartwatch EKGs will allow for greater accuracy of AFib burden in patients? Or in its current state, does it just add noise and consults?
Oh, that is an experienced question asker right there, because like me, he's gotten 100 phone calls saying, my smartwatch is beeping at me saying AFib, what do I do? So I think it's a real mixed blessing. My sense is that as those devices get better, and some of them are really very good now, it really is very helpful in terms of assessing burden of atrial fibrillation and certainly of correlating symptoms with rhythm. So I'm a big fan. I mean, I have no ties to the company. I recommend Cardia to a lot of patients, or it could be Apple Watch. It doesn't matter. Not because it's a perfect assessor of post-procedure AFib burden. I mean, if you want to do a study and really get at that, then implant a loop or put people on a month-long ambulatory event monitor. But in terms of, I had an AFib ablation 6 months ago, I'm having these funky palpitations, what do I do? It's just so nice to have a patient send you a strip to correlate rhythm with symptom. So I'm a big fan. I don't think it creates more noise than signal. I think if we do research, we do research studies where we use ambulatory event monitoring. And I just think you have to be honest in the methods section and say, look, we didn't monitor people continuously for a month. This was patient scheduled monitoring and symptom rhythm correlation, but I'm a big fan.
Excellent, thank you. And then from Dr. Bylash, what is more important for AFib, hypoxia, ischemia, or hypercarbia? And then aren't most cardiac thrombi associated with poor LV function?
Yeah, so limited LV function is clearly a major risk for atrial thrombus formation. And I think that gets a little bit at the congestive heart failure component of the CHADS-VASc score. Excuse me, but we recognize that as a unique risk factor. We've had a lot of hullabaloo here during COVID about how to do pre-procedure assessment of left atrial thrombus. Do we do TEEs, which is gold standard, or can we do a contrast CT, which is the new kid on the block? And we just wrote a paper recently saying that we transitioned from TEE to CT in part to spare the procedure of getting up in someone's face and risk of COVID. Well, the kicker was that we identified that the highest risk group that we didn't want to do that with was the heart failure group, because there does seem to be something uniquely thrombogenic about low flow in the ventricle that leads to thrombus formation in the atrial appendage. So I think you're right on that that's a particularly high-risk group. The other group that's worthy of mention, by the way, are the hypertrophs, because that seems to confer an increased risk of stroke. In terms of your other question, hypoxia, hypercarbia, ischemia, the answer is I don't know. That's beyond me. It's not. The answer is I don't know.
Outstanding. Terrific. It looks like there are no further questions. I want to thank you again, Dr. Spragg, for a terrific talk. And
this was great. It was a hoot.
We're so grateful to you for giving it to us. I hope you all have a wonderful day.
I just wanted to say thank you. It's my honor. It's such a it's very nice to be able to touch base with UCSD. It's been part of my life since I was 6 months old. Greg Feld, who runs the EP program there, I haven't met personally, but when I talked to Hugh Hawkins, who's my boss, said, oh yeah, he invented the world of atrial flutter ablation, came here to Hopkins to teach us how to ablate atrial flutter in 1992. So the ties are there, and I'll be quiet now, but I just wanted to say thank you. It really is my honor.
Have a great day, and I hope to see all of you again next week at Department of Medicine Grand Rounds. Thank you.
Thanks.